stragglers come in, but I want to say good evening and welcome to the Community Memorial Hospital Town Hall meeting. This is our last one, and it's been a light turnout. I appreciate everybody that's showed up to the meetings. My name is Frank Popejoy. I am the board president of the Community Memorial Hospital, and I've been on the board for 8 years. And at this point, I want to recognize some board members here, Jerry and Sandy, and we've got Director of Nurses here, and we're pleased to have all of you here. It shows you have interest one way or another in the proposed half-cent countywide sales tax to support the provision of healthcare services of CMH. And all the blue signs you see on the highway, maybe not further, but here going to Marysville, that's a H that you see on there. That shows you where to turn off for professional help. If you were to need, hospital help or clinic, we've got it there. But that's an important sign when you see that on the side of the road. So everybody's well-trained, educated group that we're lucky to have here in Marshall County. Tonight we'd like to discuss how you can hopefully support an effort to help CMH continue providing quality health care. Some of you here this evening may be in support of the proposed sales tax, some of you may be in opposition to it, and still others may not have made a decision yet to either support or oppose. Our goal tonight is to provide you with factual information and data related to the proposed sales tax issue. It is not our intent to necessarily to change your mind, but rather to provide you with answers that will help you make informed decision at the ballot box. It is our hope that everyone at this meeting will be treated with respect and courtesy and conduct themselves in a friendly and civil manner. To that end, following our presentation, we will open up the meeting for questions from the floor. We're going to ask that you limit yourself to one question each the time you are recognized. Once your question has been answered or addressed, we will allow then someone else the opportunity to ask a question. We will continue in that manner until either the questions have been answered or we reach the end of our allotted time as published in the announcement. If at the end of that time you have unanswered questions, please feel free to visit with one or more of us before leaving. We're going to take every effort to stay on topic of the proposed sales tax. Should we stray from that topic, it is my job to get us back on track. As an example, all of us have, at some point in our lives, had unsatisfactory experiences with business. Our forum tonight is not to address those or similar off-topic issues. And with that, I'll introduce Curtis Hockman.
All right, thanks, Frank. I don't think I'll try to stand. I don't know how long I'll be able to stand, but I had a little medical help myself here just a few days ago or yesterday. So my name is Curtis Hawkinson. I'm the CEO at the CMH. Proud to have been in the position now for almost 18 years, and grateful the board continues to employ me, so I appreciate that. Today, I'm going to talk a little about rural health care, kind of a national perspective, and kind of talk about rural health care in a state perspective, and then kind of talk locally about our situation here in Marshall County. By most demographics, the population in our rural environment usually has more comorbidities or sicker. I'll show you some slides about how many comorbidities people have in rural areas. We tend to be a little older in the rural environment. We serve most of our Medicare beneficiaries, veterans, and so on. And we're a little less wealthy in the rural environment as well compared to our maybe statewide averages. Also, we're all seeing workforce shortages. Continues to be a national issue, mostly with nursing. There's a severe nursing shortage in our country. along with other licensed areas as well. And we typically will see more uninsured in the rural areas than your urban counterparts do. As I have noted, heart disease in small town America is 56% higher than in metropolitan areas, or more starkly, by some 26,700 excess deaths due to that issue and healthcare availability. Chronic lower respiratory disease is 75% higher. Accidents and injuries also happen higher at a higher rate in rural areas. Cancer fatalities have declined nationwide, but from 2003 to 2017, they actually fell at a slower rate in rural America. And then also now there's a widening gap of almost 3 years of life expectancy between urban and rural dwellers. So kind of graphically, percentile rankings, 69% of our populations are over 65 compared to a 33% ranking for urban areas. We care more for people with diabetes, and we have a higher diabetes rate in rural America. Veterans, we serve more veterans as a group in rural America. Access to primary care typically is less. I don't really feel that way here in Marshall County. I feel that we have great access to primary care. And access to mental health, which I'd probably say we're probably in that area of having lower mental health professionals than our urban counterparts do. This slide here really graphically depicts where the prevalence of Medicare patients that have 6 or more chronic conditions. And as you see here, that's not going to work. Marshall County, which is right here, does have a higher percentage of chronic conditions than either our counties to the east and west. So we have about 10 to 13% of patients that have chronic conditions. Mostly in the rural environment in America now, we're starting to see maternity deserts where hospitals have dropped their OB services. A lot of times, there's a big variety of why that happens. Sometimes it's just flat out population declines. The number of people having babies is less, and so really facilities have to realize what's can we continue offering that service to so few people. OB and labor and delivery takes a lot of human capital to perform, and it's not. I think that people have not chosen to give that up over time based on population and human capital that it takes to run a program. And as a consequence, rural women in rural communities are more than the recommended 30 minutes from a hospital offering maternity services. And graphically, here it is in 2010, half of the rural hospitals provided OB. Now we're down to 41% of the hospitals that do. Conversely, that means 60% of the hospitals that do not deliver babies anymore. And also, not just the smaller communities, we also see the decline in what we call rural metropolitan communities that are probably in that 20 to 30,000 population range have declined or discontinued their OB services as well. Obviously, if you're not offering the service, it's more time to go to a hospital that does deliver, adds more time to getting there and getting the service. That's not, that's kind of the reality that we face here in rural America. Also, nationally, what we've seen with rural hospitals now, over the last number of years, since 2010, 149 rural hospitals have closed, which creates a lack of access to care. It loses jobs that were there before. The primary workforce is a major employer for primary care workforce. And as we have now, almost half of the hospitals routinely losing money in operations. Reasons for the closure, we have reimbursement. Since 2012, we've been in a sequestration. And we've also reduced our bad debt reductions that we used to get paid for. We're seeing low volumes happen, lack of insurance coverage, high deductible plans. That's not uncommon anymore to see somebody with a $10,000 first dollar coverage deductible. And we also know that some of the information that we've seen is that, most Americans have a hard time coming up with $400 to pay for a bill. If they had forked out $400 at the time for a service, they're not able to do that, most Americans. This is kind of a chart. As I noted, 46% of the rural providers have negative operating margins. As is the case in Kansas, we have the most critical access hospitals in the country. We have 85, critical access hospitals in the state of Kansas, and roughly half of them operate at a negative operating margin. Where the distressed hospitals are, we have 15 that are in severe financial distress here in Kansas. I know just recently, this past year, Harrington closed their hospital. St. Mary had a hospital there that they closed. And there's been some other ones, I think. Went down back to Wichita and closed recently as well. Wellington, I think they closed their hospital in Wellington. So it's a reality. Kind of some more up to date, 8 more closures in 2023. Right now, recently some data coming out. 700 are at risk of closing. They've identified Kansas as 62 hospitals that are at risk of closing. 360 hospitals are at immediate risk. And Kansas has been identified with 31. As I noted, 8 Kansas hospitals have closed since 2015. And obviously, when closures happen, you're just farther away from access to healthcare, which is something we don't want. That, one of my personal missions and passions in life, and kind of why I went into rural healthcare is, we in rural America should not have to have less healthcare just because we choose to live in rural America. And part of my personal mission is to make sure that we have great access in rural healthcare to the communities that I've been in. We don't want to eliminate services. We don't want to be less than what we're capable of, but sometimes you have to make those financial choices, and hence is kind of why we've asked for the sales tax help to help us be as strong as we can. Here's some graphic information about our uncompensated care levels. Since 2019 to 2023, we've written off, probably on average about $1.5 million to people that are unable to pay their bills or won't pay their bills. And that's really 2 buckets there. One is the charity care. People do fill out an application for charity care. If they don't choose to do that, then it usually goes to bad debts and to collections and so on. This year, I can say we're probably on pace to about, say, 2 million by the time we get to the end of the year. I think we're over 1.5 already through 9 months of the year. A few months to go. There's our operating income. We've had a good spike there when we got a lot of COVID monies. We got, about $6 million in COVID monies over the years. Through that time, everybody was getting paycheck protection. We received phase 1 funding through COVID, and that was a big help. It was a tremendous help that we received. But now, since 2021, we're kind of back on where we were before. And last year we lost 1.8 million, and it's probably a similar projection this year. Sales tax for CMH. I would also say that 85% of the rural hospitals in Kansas do receive some tax support, either in the form of maybe they're part of a hospital district, or they are a county hospital where they get mill levies from the county, or mostly now what we're seeing now is many of the hospitals are asking for sales tax support from their counties. Just some area hospitals around here that do receive sales tax. Omega receives about $1.8 million for their operation down there. The Place Center receives about $600,000. Nemaha County hospitals also about 10 years ago implemented a half-cent sales tax, and they share the $1.1 million between the Bethel and Seneca hospitals. And then Washington County hospitals, when I last checked, was receiving at least $200,000 plus per year. So the half-cent sales tax, it's 50 cents on a $100 retail purchase. Sales tax for Marysville, and every city can kind of set their own tax rate for a city sales tax, adding in back the county and the state. And so Marysville would remain at 8.6. And comparatively, we still are a little bit lower than Seneca, similar to Washington. Manhattan's at 9.15, Wamego's at 9.25. Junction City is 11.5% sales tax. Blue Rapids and Waterville listed there 9 and 8%, 8.5% respectively there. I don't know about the Junction City and Leavenworth, Kansas. They both are at 11.5%, so I don't know if they try to get extra money from the military folks there or what, I don't know, but they seem to have unusually high sales tax. Sales tax does not rest solely on the property owners or citizens, people that drive through, stay at the hotel, stay in town, drive through, also contribute to sales tax. And as I said before, it's not a property tax or a mill levy as well. This has brought in about $1.1 million per year. It's really been a godsend for our organization to continue to operate in the fashions that we have and been accustomed to. So we do feel that that's an appropriate amount. A half cent sales tax will come up for a vote in 5 years again for us to go ahead and let the folks know this is our second time now doing this. The sales tax passed 5 years ago, and so we said we'd come back and revisit the issue again and let the taxpayers weigh in again. And so we're still hopeful that the taxpayers of Marshall County will approve the sales tax vote for another 5 years. We've been in an inflationary environment. I think we've all seen that with all our bills, whether it's insurance, property, insurance, the like, pretty much everything. And obviously with, competing for salaries and so on, we definitely we feel that as well. That's really a lot of our increases over the last couple of years have been salary increases, keeping competitive with wages, and like just about pretty much every category that we pay bills on have gone up as well with inflation. Workforce competition is still, still challenging. It's something I have to work on all the time to be competitive and make sure that your workforce is engaged and we've got great environment to work in, because all those things are important to keeping your workforce. We're also seeing a changing rural healthcare environment. We're starting to see a lot more Medicare Advantage. Medicare Advantage, while it may be a little less cost premium for the people that choose Medicare Advantage, but it creates a big problem for hospitals and physicians that have to navigate within their really bureaucracy, because you have to get everything approved by the insurance company before they'll pay anything, and oftentimes they'll change their mind after you've done something, and they'll still deny the claim. You have to fight to get it. So I know we've got some legislation that we're working on with our state legislators, and we're just buckling under the bureaucracy of these health insurance companies and providing all the information that they want, and we're still getting denials, and it's just a lot of places have quit working with them. A lot of places have chose not to participate, but they still come to your facility. You still got to take care of them, and statute-wise says they only are obligated to pay what the Medicare fee schedule is, and so the patient ends up spending more because it's out of network, so it's more out of pocket for them, and we still have to fight and do the pre-authorization. So you just as well participate because you almost have to anyways. But it becomes an issue. We've had to increase our people that do pre-authorizations, number of staff in that area, just because more and more is required all the time. Increases in our IT and EMR capital expenditures, IT, information technology, and electronic medical records. We've all read in the papers how much ransomware, people are getting hacked all the time, and it's become a huge issue for us in the hospital environment to try to keep our information safe, and so that that has a tremendous cost to have firewalls, subscription services to a lot of different things, adding more IT staff to handle the volume that we have, and more people, all the devices are connected and want to be on the network. So we've increased our network capacity by 4 or 5-fold all the time. just because everybody needs to be connected. And it's a risk. I mean, it's a big risk area. If you're not following all the regulations of trying to keep your information safe, then you can get fined and have more hacking. So, I think unfortunately in the United States, we've made a prize out of getting hospital information, hospital patients, because we know that people have been paying the ransom. And so now they know that hospitals have all this data in there they have to protect, and so it's a challenge now for people trying to hack in there because they know there's a pot of gold there. If I get that information out there, then I get more money. And so it's kind of created a problem in some sense because we made it valuable for people to hack it. And we need to do our level best to try to keep it safe, of course, but at the same time we've almost created an incentive for people to try to hack into hospitals and try to get patient information, and because they know it's lucrative. And also, I would say too that we do benchmark our operations to other critical access hospitals. I know this graph is not very easily seen, but this is our Heartland Health Alliance. It's a group of about 53 to 54 rural hospitals in Kansas and Nebraska. And here we are. We're right here. We have the lowest inpatient direct cost per case per patient. So when they did this graph here, so I was very pleased that we are low cost. We do keep an eye on our costs and try to deliver the best for our patients for the amount of money that we spend on it. And kind of some affirmation there that, yeah, we are a lot lower than a lot of places are for cost. And so, Medicare pays you on cost. And so, and so that's kind of how we drive a lot of our charges is based on our costs that we have. And I feel, that we try very hard to keep low costs and not be frivolous in spending. And this graph kind of illustrates that, yeah, we are a low-cost provider. I always like to end with hope in rural healthcare. It's not all doom and gloom. I do think, rural healthcare is, receive some of the best care in rural healthcare. As I'll show you, we've won a lot of awards for patient satisfaction, for our quality scores, and for our patient satisfaction and cost scores. We tend to do more with less. We believe we have good rural work ethic. We have ingenuity. We have fortitude. We march on through the most challenging times. I can remember through COVID. I couldn't be more happy, and those were very challenging times. We kept a lot of patients here and took care of them and pulled them through. We kept very sick patients, people on ventilators, and we had no place to send them. There was no hospital beds in 600 miles that we could take a sick patient. So we did our level best, and our physicians and nurses and everybody stepped up to come up with new protocols to take care of somebody on a ventilator, and things that we generally don't do routinely, but we did. We figured it out and pulled a lot of people through. In the rural environment, you'll generally see that your scores are higher for quality, or higher patient satisfaction scores generally are higher. We're cost effective and use fewer resources. And I would say healthcare is so fundamental in rural healthcare. It's important as any form of infrastructure that we have. Very proud of our staff that we've been able to assemble over the years. A general surgeon and very well qualified, well experienced family practitioners. And also say a great word about our nurse practitioners that we have that work in various areas. There too, we have a lot of experience in our nurse practitioners. Everybody is probably at a minimum 20 plus years of experience working in the healthcare environment. I think that's a big positive for our community.
See, I just said a decade last week. Age and timber.
And we have great specialty clinics. We have a lot of specialists that come to our community, and they don't have to come. Generally these specialists are probably busy enough where they're at, but some of them do have a soft spot in their heart to go out in rural communities and provide service. And so we're thankful for the ones that do, and see patients here locally. It makes a big difference to a lot of people that are having a hard time driving or getting to places far away. And they're able to come to CMH and see the providers here. As I noted, we've been a top 20 hospital award winner for the last 3 years, 21, 22, and 23. And kind of what I said earlier, that encompasses about 1,300 critical access hospitals in the country. And so we're in top 20, so that's really kind of amazing to think about that. But the things that they look at, and it's not the information that I send in, it's information that is in the public space. When we submit our cost report to Medicare, we do submit our quality scores. It's also a CMS or a Medicare program that we have to submit our scores through. And also our patient satisfaction scores. There's a third party that administers our patient satisfaction scores for our inpatients. There's like 28 questions that they have to answer. And there again, it has to be done by a third party. It can't be us administering the survey. They have to do it through a third party. And through all those things, then they create the top 20. And just proud of our organization, the people that choose to work there. We're able to say, hey, we're a top 20 rural hospital in America. So I think that's to be very proud to be part of that. And we've been a top 100 critical access hospital. We were a top 100 for a number of years, and then we finally broke through in 2023. 2024, we're also was named a top 100 hospital as well. We've been a 5-star rated hospital by CMS. Currently, we stand at a 4-star rating. 5 stars is hard to get there. We got there one time, so we hope to get back. I know they've made some recent changes to their formula to how to calculate that. They felt rural hospitals were doing better than the urban hospitals because, I don't know, they just felt they were disadvantaged somehow. And so they changed the formula, so it's not quite so much rated on some certain aspects of the score for the 5-star rating, but we're a 4, and hopefully we'll get back to 5. When I was kind of researching, there were some articles that I read. The Marysville Advocate, Byron Guys, was the owner at the time, and he wrote this in the article that I read. They're trying to create the hospital in 1958, doing a fundraising drive, and he added these words here. He said, "No doubt there'll be trying times, but if every person remains loyal to the hospital, it will serve one of our greatest needs that this community has ever had and always will need. Let us resolve now to ever work for the best interests of the hospital because it belongs to everyone." And it truly does. We're a nonprofit private corporation. Back in 1958, they kind of had a capital fundraising drive. They wanted $100, and then people could be part of the association, the CMH Hospital Association. And so that's really been the same since 1958. So even today, if you want to be a member of the association, you can pay $100 and you can get a notice to the annual meeting. And at the annual meeting, we go over our financial results, our CPA firm that comes and gives us those results. We vote on board of directors, and then if there are any bylaw changes, the members vote on any bylaw changes. But nobody gets a dividend. It's not a stock membership. Nobody gets a remuneration for being a member of the corporation. As I said back in the day, I think it was a fundraising drive to build some funds to build a hospital, and it's been that way ever since. And if the hospital would ever have a dissolution or close or merge, the nonprofit dissolution process requires the state of the Kansas Attorney General to actually approve the process or what the end result of that charitable organization will be. Many times I've seen where they've closed and they've created another foundation, especially if there's monies paid for the building and they turned over the assets to someone. They generally create another foundation to be in its place to help the public welfare of Marshall Countyans, whatever aspect that they may do. But I've seen that in many states where the health system comes in and buys maybe a nonprofit hospital, and then those monies go into a foundation to serve other issues or other things related to healthcare in that county. So the ballot question will say, shall a retailer's sales tax in the amount of 0.5% be continued in Marshall County, proceeds of which will support the provision of healthcare services by CMH. The continued collection of said sales tax shall commence April 1st, 2025, and terminate upon the first to occur if the following 5 years have lapsed since the implementation, or CMH has merged or been purchased by another entity, all pursuant to County Statute 12-187. So we're asking you today to keep our pulse strong for CMH and vote yes for CMH. I think it's a worthy cause. Also I tell our folks that we do orientation and so on, and I guess that's also part of our vision too for as a hospital is, we want the county or the people that use the CMH to be proud of their local rural hospital and say we've got an asset there, and we're really proud of it, and we're happy that it stands strong and is there for us and has been there since 1958. And so I guess that's what I tell the orientation, when we do orientation, I said really our goal is to make our community proud of the rural hospital.